Start. Good evening, sir. We'll start. It's 6:30. Good evening. I heartily welcome one and all for this Physician Day celebration virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. Brief history of API. The oft-repeated desire of many was changed to reality when a group of physicians met in Madras, Chennai, and decided to form an association to promote the interest of those whose main occupation was internal medicine. They drew a memorandum on a set of bylaws and registered a body in Madras on 23rd December 1944 and called it the Association of Physicians of India, namely Dr. Jivaraj Mehta and Dr. A. Guruswamy and others. It was dream come true of our own past president API, Dr. Muruganathan sir, who took initiative in Epicon 2013, Coimbatore, to announce to celebrate every 23rd December as Physician Day and conducted all academic activities for a week long all over the country according to convenience. Hence, today we are doing this program by conducting academic activities, update and honoring great physicians of the country. As from past 1 week, we have seen celebration done at national, state level and many others at other places of the country. On this occasion, I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bangalore. Welcome Dr. Shivraj Alshetty, President MESOT, and Dr. Murugesh Pastapur, Chairman API and team. I welcome our guest of honor, Dr. Muruganathan, past Governor ACP India Chapter, past Dean ICP, and past President National API, who needs no introduction. I welcome Dr. Gundal Narsimlu, our own alumni and Chief Rheumatologist and past Dean ICP, a great academician and a teacher from Hyderabad. I welcome our guest faculty, Dr. Raman Ganga Kherkar, a past scientist, ICMR, and epidemiologist, a Padma Shri awardee, a great researcher, a scholar, and a scientist, and teacher with many publications, both nationally and internationally. I also welcome our chief moderator, Dr. P.C. Manoria, chief cardiologist from Bhopal, past president of API, CSI, and so many other organizations, a teacher par excellence, a great name in the field of the cardiology in the country, a great academician, a clinician, and a researcher. I also welcome our panelist, Dr. B. Murali Mohan, chief pulmonologist from Bangalore, Narayan Rudalia, a dynamic personality in the field of academics with many publications and great teacher. I also welcome our other international panelist who has joined from UK, Dr. Radha Sundaram, a chief intensivist who was involved in COVID-19 management and in local guidance developments in Royal Alexandria Hospital in Paisley, United Kingdom. I also welcome Dr. Jayant Antani, our own faculty who has joined from Pune. Lastly, I welcome our chief guest of today's function, Dr. Y.P. Munjal sir, the Doyen of API and Director PRF, a great academician, teacher, researcher in the field of medicine in the country, who needs no introduction, a respectable name in the family physician family of the country. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating the third wave or surge shortly. Let us not waste time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them at their respective specialty. As I can see, more than 100 delegates who are registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life. That speaks how powerful the speaker is. Now we have a formal virtual inauguration.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya Deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam आरोग्यं धनसम्पदः दीपज्योतिः परब्रह्म
On behalf of all the associations and members, we are virtually honoring all our guest faculty for their tremendous contribution to their work done in their respective field in the country. The citations will be delivered to their respective workplace. By honoring Dr. Y.P. Munjal virtually today on Physician Day is as good as honoring the whole physician community of the country. And I also honor other guests of honor, Dr. P.S. Shankar, Dr. Muruganathan, Dr. Narsimlu, Dr. Ramana Gangakhedkar, Dr. Manoria, Dr. Murali Mohan, Dr. Radha Sundaram, and Dr. Jayant Antani. By felicitating all these great physicians of country is as good as honoring the members of their institute also. I request to all to accept the same. Now I request Dr. P.S. Shankar to address the gathering.
Dr. Munjal, Dr. Muruganathan, Dr. Narsimulu, Dr. Gangakhedkar, Dr. Manoria, Dr. Murali Mohan, Dr. Radha Sundaram, Dr. Antani, Dr. Alsetti, Dr. Sangram, Dr. Murugesh, and friends. Thank you very much for the honor. I am happy to be in the Physicians' Day celebrations and the update on COVID. The Association of Physicians of India is a professional body of the physician and was established on 23rd December 1944. Following a meeting held by the leading physicians of the country, 9 physicians from different parts of the country were the signatories. I am proud to say one of the founders, Dr. M.R. Guruswami Mudaliar, hailed from Karnataka state and was in the state medical service at that Mysore Medical Service. And later, he migrated to Madras. I used to meet some of the founders like J.C. Banerjee, George Coelho, M.J. Shah, N.D. Patel during the conferences. And also enjoyed the hospitality of the Chief Minister of Gujarat, Dr. Jivraj Mehta at Ahmedabad conference. The body has grown since then with more than 20,000 members. The day is celebrated as the Physicians' Day, unlike other days where they are celebrated on the birthday of a great personalities. Here it is on the organization. 2 years ago, we knew nothing about the COVID, though coronaviruses were known to in some parts of the world. On the last day of the year 2019, corona infection made its appearance in China and spread worldwide, making it the worst pandemic. And the COVID had kept the world on the toes throughout 2021. We know nothing about the cause, the mode of spread, the manifestations, diagnosis, and treatment. Slowly, we gained knowledge about the corona infections. Its causative agent was recognized, its mode of spread, and its varied manifestations. Lot of medications were tried to control the infection. Within a year, the vaccines were discovered and new strains have emerged, of which the Delta variant is prevalent in our country. Now another strain, Omicron, is attacking the mankind. It is attacking the people who were earlier infected or vaccinated. Thus, it is nicknamed as Delmicron. India is anticipating the emergence of a third wave. Even after vaccine, we cannot neglect the preventive procedures such as the face mask, the social distancing, and the hand hygiene. Dr. Gangakhedkar, who has a vast experience on COVID, is here to speak on the COVID past, present, and future. I am glad my good friends Dr. Munjal, Dr. Manoria, Dr. Antani, Dr. Muruganathan are here, along with my old student, Dr. Narsimulu. We look forward for a good discussion on this topic. Dr. Sangram has taken a lot of trouble to organize this particular program. I am glad to associate myself in the inauguration of this particular program. Thank you very much.
Thank you, sir. Thank you for your kind words of wisdom. Now I request Dr. Muruganathan to speak few words. Over to you, Dr. Muruganathan.
Mr. Inauguration.
Thank you, Sangram. Thank you very much. Hello, can you hear me?
Yeah.
Yeah, go ahead, sir.
Go ahead.
Okay, so I am very glad, even in the airport, Bombay airport, I'm giving a talk. I just checked in now. So I wish all of you a happy Physicians Day. In fact, all over the country, people are celebrating Physicians Day. I told them even this whole week we can celebrate. And I think Sangram has taken a very good initiative. And my elder brother, Dr. Munjal, is the chief guest, and another elder brother Shankar is there. So we are really honored to have all of you in the same page and same platform. And Physicians Day should be celebrated every year and should honor everybody who are really good. In fact, in my opinion, every physician should be honored because we are saving so many lives. Recently, Christine Barnard said, I have saved 150 lives by 150 transplants. If only I would have taken preventive cardiology or preventive method, I would have said 150 millions. Every physician is saving so many lives every day. So we must salute all the physicians, COVID saviors, and we are very proud to be physicians. So happy Physicians Day. Kindly continue to rededicate your service to the humanity. And I'm very happy that my elder brother Munjal is there, and he is always a motivator and inspirer. And Shankar is always a nice person to move with and a very eminent physician in this country. So I wish all the speakers, faculty members, and the audience a happy Physicians Day. And today we have chosen a very nice topic, COVID, past, present, and future. I wish Sangram all the best. Thank you. Over to you.
Thank you, sir. Thank you for your kind words of wisdom. Now I request Dr. G. Narsimlu to address the gathering for 2 minutes. Over to you, Dr. Narsimlu, sir.
Can you hear me?
Yes, sir. Yes, sir. Go ahead.
Yeah.
Great, Sangram. Respected Vaipu Munjal, our elder brother, our Dean of API, and mentor for all of us, Dr. P.S. Shankar, Dr. Jayant Tantani, Dr. Suraj Alseti, who are my teachers, and Dr. Sangram brother, Murugesh, Dr. Muganathan, again my elder brother, and the speakers, and the speakers, Ramana and Murli Mohan and Radha Sundaram, and my good friend, Dr. P.C. Manoria, who is a moderator. I'm happy to share our wisdom and here and take the wisdom of the COVID. As P.S. Shankar told, 2 years back, we were not knowing anything about the virus, how it is spreading. We thought of format, now airborne. Then how long the virus persists in the body. Different drugs have been tried. Still 1 or 2 drugs have come with some success. And if I remember, last successful vaccine, polio took nearly 35 to 39 years to see the light of the day. Within 1 year, we have discovered more than half dozen vaccines and nearly 90% of the population vaccinated. And we also learned of the mutation, how it takes place in the virus in multiplication. And we have gone through a tough phase. Most of the tough and difficult phases are borne by physicians and pulmonologists. We know how much society, government recognizes or not, but we should be proud of the people, especially one who sacrificed his life in the caring of the people who are suffering from COVID. And especially in Hyderabad, the Gandhi Hospital staff was totally burnt out because in the beginning, government permitted only Gandhi Hospital to treat COVID. Now it is there in almost private everywhere. I wish this discussion goes well. In my own rheumatology, we learned a lot of COVID infection impact on rheumatoid arthritis, SLE, vasculitis, and various tissue-modifying cytotoxic drugs, steroids, how it behaves. And these 2 years have changed our lifestyle. We have become more knowledge. And also, I'm sorry, it is very heartening to see some of our colleagues left us. We wish the soul rest in peace. I wish this meeting to be successful, knowledge gets spread again, more and more. Thank you, Sangram.
Thank you, sir. Now I request our chief guest, Dr. YP Munjal, sir, to address the gathering. Over to you, Dr. Munjal, sir. Dr. YP Munjal, sir, kindly unmute and speak.
Is that all right?
Yes, sir. Yes, sir. Kindly go ahead.
First, I would like to address a very dear friend and a role model for API, that is Professor P.S. Shankar. He, as scientific chairman of API, brought out an excellent monograph on progress of medicine. We have another fiery brand physician, Dr. Muruganathan. We have another doyen from API, Mr. Jayant Antani, Dr. Narsimullu, and to name Dr. Sangram Brother, who is the nerve center of this program. I would like to thank the Gulbarga branch for having bestowed this honor to me. And the topic of discussion is very timely, because over a period of time, we learned that COVID, after the symptomatic relief, continues the so-called long-term COVID. And a recent study has found out that the virus can replicate itself in the various organs of the body, like heart, brain, kidneys, and this explains some of the unexplained answers of clinical symptomatology which we saw in COVID. So therefore, a topic of immense importance, especially we know that mutations are possible like influenza in the COVID virus also, and therefore we need to continuously strive to have vaccines which will cover the newer strains effectively. With this, I once again compliment Dr. Sangram Brother and other dignitaries of the Gulbarga branch who have put together the various learned speakers from all over the country as well as the international speaker. My dear friend, Dr. P.C. Manoria is going to moderate this session for you, and he is a professor who has taught many people and established a cardiac center at Bhopal by his sheer hard work. My compliments to Dr. P.C. Manoria. With these few words, I thank and wish the program a grand success. Thank you very much.
Thank you, sir. Thank you for your kind words of wisdom and sparing your valuable time. Now we move on to the scientific session. Now I request Professor Dr. Raman Gangakhedkar to deliver his talk on COVID-19, past, present, and future status in India. Over to you, Dr. Gangakhedkar, sir. Kindly make it full screen, sir.
Yeah, I am. Thank you, Dr. Biradar, API Gulbarga, to have invited me for this talk. Now, what we will be dwelling on is COVID-19, its past, present, and future status in India. I must also admit that these are my personal views. We know that the virus is very smart. Whatever we may try to predict, there is always a possibility that it may not happen exactly. And that's something which we have to keep at the back of mind. Now, since we are going to dwell on past and present, as was asked to, I will try to be little hurried in the presentation to begin with, and then we will try to understand what are the future implications. Now, all of us know that the asymmetric warfare, the guerrilla warfare, began in January 2020, the virus was adopted a respiratory route for spread of infection. The majority of them who got infected were largely asymptomatic, and it tends to kill those who are weak and old. And that fight, guerrilla warfare, actually began then. We took this virus very seriously. Within a short span of time, we understood that if we have to fight against this virus, we may have to start a lockdown to try and use that opportunity to delay the onset of this curve and try to ensure that our preparedness tends to improve dramatically, whether it is in terms of manufacture of PPEs, disinfectants, ventilators, RT-PCR machine, even oxygen supply and the reagents that you require to diagnose, and also create ICU beds facilities and train the manpower. And then if you actually see, that was fairly successful because, by the time we ended, we delayed that particular onset significantly as we generally see. And that made a huge difference because it provided us time to have that preparedness. As you might see, even in this graph on the right side, that perhaps the wave started off sometime around end of May or end of May or June, and then it went up significantly. But when it went up significantly, at that time, we had less than 100,000 cases that were occurring at the peak of this particular epidemic. However, one thing which happened, which generally is always likely to happen for new preventive behaviors that we ask people to adopt, we started seeing that the mask use started dropping, the cell phone mobility as a measure of how freely people were moving in the society. You find that that had also dropped significantly. People were moving very freely by the time it was around February, and also that the number of tests that we were providing at that juncture, they were almost 60% of what we were at the peak of this epidemic. Now, if you try and look at the end of December scenario, most of us were very happy because there were various vaccines which were receiving EUA, and in India on 3rd January we provided emergency use authorization to Covishield and Covaxin. These vaccines reduced the incident infections that could occur and also the disease severity and death that could be an outcome of these infections among those who were highly vulnerable. A frantic effort was launched by different governments in different countries to vaccinate people, but that was largely affected because large number of people were to be vaccinated. There was a lower manufacturing base in terms of vaccine dosages that we can manufacture. Advanced purchases of vaccines by wealthy countries created its own set of problems because basically some of these countries had booked for larger number of dosages per person, and that's something which we have to keep at the back of mind. And the IPR, intellectual property rights, were never shared. The result was it impacted our performance per se. Then all of us remember that we had to face a huge Delta upsurge, the upsurge that occurred because of emergence of Delta variant, and it almost replaced all other variants very quickly in India. And that's something which led to a huge stress over the healthcare system per se. If you try and look at the evolution of this virus, initially, if you recall, the Wuhan virus was perhaps it evolved into one virus which had D614G mutation almost 6 months after the detection of Wuhan virus. And then what followed was beta, alpha, gamma, and then largely, by the time it was around April, you found that the Delta was replacing everywhere. But you just look at this particular graph, one thing which we realized that within a short span of time, we found new and newer variants were coming. But then by the time we were engrossed with that news that Delta is spreading across and it went down, you suddenly find that we thought that we may be moving into a different era altogether. We'll come to that issue subsequently. But we know that during the Delta variant's second wave, you realize that we quickly went up to a very high number of about 4 lakh people getting infected every day. And this particular wave lasted for a shorter period compared to the first wave. And that's an attribute of only one thing, that if the variant tends to spread rapidly, they will infect all those who are vulnerable as quickly as possible. So the wave has to come down very quickly. And that's essentially what we saw with respect to second wave per se. Now, at that juncture, ICMR conducted 4 national sero surveys in the past. The fourth one was done in June 2021. And there it was found that 67% of the population that was surveyed across the country, that was actually having antibodies against COVID. Only about 32% of the people were not having antibodies at that juncture. So people thought that vulnerability is reduced to a larger extent. And this was at the backdrop of one thing, that close to about 62% of the people were unvaccinated in this particular study, and only 13% of them had both the dosages of vaccine, which essentially alluded to the fact that a large majority of those who had antibodies were actually infected due to natural infection that was seen during Delta wave. And then all of us started speculating that perhaps the numbers, of those who have been naturally infected would have been very high in the subsequent period also. And most of us went back to one thinking that, if you look at Spanish flu ended with 3 waves which were significant enough, and perhaps we may not have to face the third wave because our second wave was pretty strong, and that kind of complacency it came in the minds of people. But look at the issue today. If you look at global epidemiology, we today are facing fourth wave across the world, and the fourth wave is actually rising far too dramatically at this time point. And that's something which is a major botheration as of now. And people were perplexed. You look at our vaccine coverage, you find vaccine coverage is high among those countries which are little richer. But if you think in terms of the African continent or low and middle income countries, you will find that proportion of those people who have received 2 dosages continues to be abysmally low. And of the total vaccination dosages that have been delivered, only about 8% of these vaccine dosages have been given in continents like Africa. At this juncture, all of us knew that was one of the most important intervention measure that we could have had adopted, because we could look at the effectiveness of this vaccination status, and we realized that if somebody is unvaccinated, the risk of that person being found as positive could be 6-fold higher over those who have been vaccinated, and almost 11-fold higher risk would be there for those who are unvaccinated for dying from COVID-19 compared to those who are vaccinated. Whichever vaccine we looked at, these vaccines had a small variation in terms of that effectiveness that we estimated. But what was worse, perhaps we did not pay so much of attention to, was different vaccines tended to have a different trajectory of waning immunity per se. So if you provide a vaccine, you suddenly find that most of these vaccines tended to lose its efficacy after about 5 months period. And then there are subsequent studies which are coming off, even shorter periods are being talked of. But by and large, 5 months was considered as one cutoff where perhaps the risk would be increasing dramatically in terms of acquisition of infection, and the boosters concept suddenly started coming up. At the same time, if you try and look at what was the stringency index, and by stringency index is the measures that the government adopts, something like calibrated lockdowns that we had, all the kinds of intervention measures that the government can adopt, these kept on changing over a period of time. And if you look at India also, you will find that these became soft and softer when it comes to stringency index. And December 20, we were almost having very little in terms of stringency index. And therefore, perhaps we had to reflect as to where we are going. Now, if you look at the current situation, currently you find that almost close to 28 crore people are infected by this particular variant so far. If you look at the deaths, there are close to about 55, 54 lakh people who have died due to this particular infection. And if you actually try and see that why such a kind of thing could happen here, you need to understand certain things. Now, if you divide these countries into different income groups, you will suddenly find that it gives you a clue as to who vaccinated the population quickly. Now, people went for advance booking of these vaccines, and you suddenly find high income group countries tended to reach this, tended to administer large proportion of dosages, and compare that with low income and lower and middle income. So what essentially happened was we divided the world into those which are vaccinated and protected countries and unprotected and unvaccinated countries, like you saw South Africa as one of the best examples at that juncture. It provided an opportunity for the virus to replicate and mutate. Now, that's something which is critical to understand, that the virus gets a different kind of opportunity for mutations when such a divide tends to come in the population. Generally, as a rule, the viruses tend to mutate since you have error-prone enzymes during replication, and since it has error-prone enzymes, you will find that mutations will become more common, and that is fueled further. If it can infect more persons, it would mean it would have more reproductive cycles that would happen among human beings. The more is the likelihood that newer mutations may come. Generally, we tend to refer to one fact, that a new mutation, which is stable, that tends to occur in this particular virus at the population level at the rate of one mutation for every 15 days. You could also see drug pressure, which tends to induce these viruses to mutate. However, drug pressure was not so strong here in COVID-19, mainly because we don't have really good antiviral drugs which we have used in the past. When it comes to immune pressure, that was perhaps one of the most important issues that we have to keep at the back of mind. This immune pressure could come from both the vaccine-induced immune protection and also natural infection-induced one. And since both tend to occur, they may differ in terms of proportions in different countries. This pressure can lead the virus to mutate dramatically. And we also know, as the variants tended to come, the ability of these vaccines to protect us tended to go down, and it went down more for the risk of infection rather than risk of disease and severe COVID disease and death. And that's something which we have to keep at the back of mind. Most of us, we tended to believe at that juncture this was more of a convenience bias, that if you look at the first wave, we said then different variants were being detected. We said that perhaps, when the variants tend to come up, they try to be good for the virus. And what is good for the virus? The good for the virus is the virus will lose its virulence and will increase the transmission efficiency per se. And many became optimistic that these mutations will benefit us. Though, if you remember the second wave, Delta proved it otherwise, completely otherwise, and Delta created a havoc in the country. And then suddenly now, you remember on 24th of November, there were reports of Omicron as a new variant that has come. Now, this variant was slightly different because it had 50 mutations added to the Wuhan virus. If you recall, in the month of October, the number of mutations that were added to Wuhan virus in October 2020 was only about 20. And then now you have 50 mutations that you are seeing to the Wuhan virus with Omicron, which is a big surprise. And therefore, people tend to speculate, how did this virus develop so rapidly and with so many mutations, and how we could not have detected it. There are different theories for the same. Of these, 37 mutations are occurring in the spike protein. 23 of them were at least observed in the prior variants which we had seen earlier. But 14 of them, we still do not know. They are new mutations. We do not know how phenotypically they are going to influence the behavior of the virus. We continue to speculate on these mutations at this juncture. Of the 37 mutations that have occurred in the spike protein, you find that 15 of them are occurring in receptor binding domain. And that's perhaps the reason why the virus tends to have very high binding affinity to ACE2 receptor, and therefore the transmission efficiency has increased dramatically with this virus. It is also seen that among these mutations, there may be some mutations which have reduced the propensity of this virus, if you compare it with Delta, to infect the ACE2 receptors through lungs, but by and large, the virus is more efficiently entering through bronchus, and therefore the typical respiratory distress syndrome is not seen as often in this particular virus, and that's something which we continue to observe at this juncture globally. The scare with a new variant when it comes is how would the propensity to spread be influenced by this variant? Does it cause more hospitalization and death and evade vaccine induced immunity? Now let's try and see where we are. It has already spread to over 97 countries globally within a span of almost a month's time so far after its detection. And I understand detection doesn't mean that that was the first time when the virus must have had, evolved. Perhaps it may have been there, but still 97 countries in 1 month is a huge number. When it comes to daily new cases that are occurring in currently high burden countries, you suddenly find you see new names, that is USA, UK, Italy, Germany, Canada, and now France, which is also contributing almost 2 lakh new cases every day. And that's something which is scary, because India, though it continues to remain at the lower end of the graph, we still do not know how things would pan out, which we will try and speculate about subsequently. You look at the epicenter, the South Africa, from where Omicron was actually described first, you suddenly find that they had a spurt in new cases that were occurring. And then if you look at the curve, epidemic curve for their fourth wave, you suddenly find that this particular wave lasted for a short period of time. It has already started coming down. So essentially Omicron, because of its high infectivity, high transmission efficiency, the number of new cases increase. But as you infect many, you will find it drops down dramatically. When it comes to hospital admissions, if you compare this particular graph with the earlier graphs, you will find earlier waves that you see in the same graph, you find that hospitalizations tend to occur lesser. And what is most important for all of us, the new deaths that occur per million population are also subdued and very less compared to what was happening in the past when it comes to second wave or the first wave which South Africa had actually faced. But what is important for us to understand that the Omicron, leads to a drop in neutralization following vaccination. So essentially what it would mean that escape mutant is particular, Omicron is like a escape mutant. You will find that the vaccines don't provide as much protection as they used to earlier. Now you look at another fact that people tended to believe that natural infection induced immunity perhaps would be able to protect them from acquiring Omicron. But one of the classical studies that has been reported from South Africa, it tends to show that the relative risk of acquiring Omicron is almost 25%, even among those who were infected before the Omicron variant came up. Now, if you look at the recent report from UK, which compares Omicron versus Delta, you find risk of hospitalization, whether it is for any days or for a longer period, it drops down dramatically. And even mean length of the stay in the hospital tends to be smaller for Omicron compared to Delta per se. these mutants by and large will continue to emerge because essentially the virus would like to see that it becomes fitter, becomes more transmission efficient, so that the virus can have a symbiotic relationship with human beings and can stay as an endemic infection in the community. Now, if you look at this particular phylogenetic graph, what does it tell you? That this virus, the Omicron, which is in the red line, is placed far away from the earlier variants that you have seen. Now, the question that tends to emerge, as it has acquired 50 different mutations. So, is this that we are likely to move from antigenic drift to antigenic shift? No, we are coming closer to that. The virus has added so many mutations in such a short period of time. And now, if you actually look at even Omicron now is known to have two different variants that are coming from the same lineage of Omicron. One is called as BA1, second is called as BA2. You must have heard a lot about the spike gene, which used to be, which never used to light up when you do RT-PCR. But later, subsequently, we have realized that that feature was only in BA1. Now the BA2 lineage, which is also becoming as common, it does not have that 69/70 deletion, and therefore even spike gene lights up. Now it has its own implication, which we will try and see subsequently. Now, what are the possibilities that tend to arise with this Omicron variant? The immune pressure and unvaccinated vulnerable population is actually leading to rapid accumulation of mutations together. It may make this particular virus benign, highly transmissible as an infection, or it may result in a newer strain of coronavirus per se. Omicron reduces vaccine effectiveness more against those who are likely to get new infections, but the reduction in efficacy is less against its ability to modify disease severity. So vaccines continue to protect us from severe COVID disease and death with this particular virus as well. Can we continue to speculate that T-cell sensitization will protect us? Perhaps not. Newer data tends to suggest that even a T-cell sensitization tends to drop over a period of time. What is it actually trying to tell us in different ways? How this infection must be occurring? When it comes to getting infected, what it is likely to be connoting is you need high titer of neutralizing antibodies at the time of exposure if you want to prevent infection. And therefore, and this is especially important at the backdrop of reduced incubation period and enhanced affinity to ACE2 receptors. And why does this become important? As the reason why we need to think in terms of providing an additional booster to people or an additional dose to an individual who has already received 2 dosages if we want to protect him from the infection per se. But T-cell sensitization, which is likely to mount response after the virus perhaps has already made the entry, it impacts the disease severity, it controls the disease severity better, and that's why hospitalization may not be occurring. Why do we need to worry about painting different scenarios? If you look at the projections that are seen globally, if you look at the peak that you might see with the newer variant, the Omicron that has come up, you suddenly realize that the daily counts can increase dramatically, and they could go as high as around 3.5 crore infections every day, as per the modeling that has been done by IHME. But what is also important for us to remember, that counting daily new infections makes sense when it is unimmunized population or a naive population from the natural infection per se. But now, when we are 2 years into the epidemic, we should actually try and look at the daily hospitalizations and deaths as a powerful monitoring indicator to understand how big is the challenge of this particular infection. If you try and see the current status of this pandemic in high burden countries, you suddenly find those that are in limelight today, like France, you compare that with Israel, UK, Spain, and USA, you find new cases are increasing, but hospital admissions haven't increased as much. Patients in ICU continue to be seen at a lower level at this point in time, and deaths I have definitely been seen lesser compared to other waves in these high-burden countries today. If you try to look at what is happening globally, if you see the left one, you will find that is actually showing you the share of SARS-CoV-2 sequences that are reported to GSAID that are mainly due to Omicron variant per se. You find South Africa has almost gone closest to the 100% mark. You have India, which has gone above 60%, but you can't overinterpret this figure because we are largely doing these sequences among those who are international travelers. So we really do not know what proportion of cases are actually occurring in our population, which can be attributed to Omicron, and is there a community spread that is occurring today. But you look at UK and USA, slowly it is trying to replace what you see on the right, the Delta variant, because Delta variant is declining at this juncture in all these countries that we talked about. The difference that we are perhaps seeing, which is impacting globally, is we have a different kind of a world epidemiologic picture across the world. One, you have a developed world where people were vaccinated first, and that was followed by Delta wave and now Omicron. A country that could describe it better could be USA, and countries that are rapidly vaccinating before Delta could strike. The best example could be Israel. Even there, they are as much worried as of now. And Delta, which was first followed by the vaccine-induced stronger response that comes as a hybrid immunity. Perhaps the best example is India, and that is likely to impact the future scenario as such. And why does this happen? If you actually see this particular study, you will find that there is a drop in neutralization, which tends to be seen as much in mRNA vaccines, adenovirus-based vaccines, or inactivated vaccines. However, this drop is lesser among those who had prior infection of COVID-19 before. Now we try to look at US and UK and try and see how much of difference is it creating. You try and look at UK, which is a red line, and then what you see as a greener line is United States. You suddenly find that if you compare at vaccine dosages, they are fairly well vaccinated places. When you think in terms of new cases that are occurring, you find that the new cases per million have rapidly gone up in United Kingdom compared to what you are seeing in USA. You look at the patients in ICU, and then you suddenly start realizing something is different here. The numbers continue to be smaller, whether they are ICU patients in ICU or the new deaths that are occurring when it comes to UK. And this difference perhaps is mainly a reflection of this Omicron variant, which is causing as much of infection there. If you try and look at UK, you will find that hospital admissions continue to be low, though the number of daily cases that are occurring is high. Patients in ICU are less, and deaths are also lesser. Now, this suddenly, people start wondering whether this Omicron is likely to cause so much of a major problem. But there is something which we have to understand. If you look at UK, their vaccine coverage for second dose is 82%. And for booster, currently it is about 57%, which means they had only 18% of the population, the way we describe as complete immunization in India. And you look at the numbers, whether it is hospitalization, new cases, or whatever. If we imagine that if India was to be in such a place, one must remember that we have almost 37% of the people still who have not been vaccinated, and our denominator is large enough. So what could happen in a place like India? New infections could increase if the community spread of Omicron starts. The numbers could be mind-boggling. They could perhaps scare you the maximum. A high R0 value could also mean that the wave will last for a shorter period and Delta. So there will be a huge spike that will come, will stay there for a very short period of time. Though there may be less proportionate impact on hospitalizations and deaths, we continue to remain vigilant, mainly because 40% of our population is still not vaccinated at this time point. So these numbers could still threaten the health services at this juncture. And why does this become important? One of a nice study of an outbreak that tended to occur in a Christmas party, it shows a different kind of a light. There were 117 people who participated in that party. They stayed there for 4.5 hours. These investigators could actually enroll 111 people who participated in that party. It was in a closed room. And the median incubation period they found was only 3 days, which was shorter than Delta. And there was a remarkable difference that among all these people who were found as positive, that is almost 81, you found that there was only one person who was asymptomatic, which is very different than what we have seen in Delta, or for that matter in earlier variants, where the proportion of people who were asymptomatic used to be very high compared to those who were symptomatic. And most of them had received vaccines. But the good part is there was no hospitalization, despite the fact, though the median age is slightly lower, but if you look at the upper range goes right up to 68. So perhaps it has lower hospitalization as we see. Now, if this particular infection becomes common in India, it spreads rapidly, there is a community spread that occurs, will we be able to pick up this infection due to Omicron? You try and look at the symptoms that they have: cough, runny, stuffy nose, fatigue, sore throat, headache, muscle pain, fever, sneezing, and there would not be so much of fatigue that we saw. There would not be dyspnea that tended to occur in Delta wave. There would not be so severe symptoms. So do we think that our people who may develop this symptom for a short period of time will come to you quickly and ask for this RT-PCR test? We really do not know, because our treatment seeking behavior is going to influence the proportion of cases that you might be eventually be able to pick up as having Omicron variants per se. Now you look at BA1 and BA2. Now what is more important for us to understand is it adds a layer of complexity, because if BA2 becomes more common, you will find that spike gene deletion will not occur. So the current approaches that are being followed elsewhere, that they tend to go to a Thermo Fisher's TACPA test to screen, and if the test comes out as positive, they tend to assume that the person must be having Omicron variant, because you don't have alpha variant there at this juncture. But can we do that here? Perhaps not. Our RT-PCR test will continue to come positive if BA2 would start predominating in India. And then its implication would be we may have to develop a new definition for Omicron variant for diagnosis, because the symptoms are drastically different. In Delta and Omicron, you're not finding people who tend to have anosmia. You're not finding people who lose their taste. You're not finding people who become dyspneic, but they come out as RT-PCR positive. Perhaps the need for doing genomic sequencing would drop down beyond doing research to find out proportionate morbidity of this BA2 variant that may occur here. If one gets Omicron infection, would it protect against Delta as well? Because you find that at the time when you look at this particular variant emerging, you will find Delta will also be there, Omicron will also be there. Our worry will be that if Delta increases, perhaps the risk of the stress that it can put to the health system can be immense. But if people get Omicron, one of the studies that has been recently put into a preprint review, it tends to show you that if an individual actually gets Omicron infection, you will find that the person would have neutralizing titers which would be effective 4 times higher even against Delta. So which essentially means if you got Omicron infection, then in those cases you would also be protected against this Delta variant that could affect the entire health system at this juncture, which is a good news in the short run. There are people who still think that in that particular case, if Omicron is a milder kind of a variant, and if it can replace Delta and also protect us against Delta, perhaps it would be a boon in disguise. At the same time, there is a new development that is occurring. There are newer antiviral drugs that are coming up against COVID-19. They may reduce hospitalization and death as one of the facets, but would it increase the spread, as these drugs are to be provided to ambulatory patients and therefore they would stay in the home and create issues in terms of spread of this infection? All of us know about Paxlovid, one of the most efficient drugs. It can reduce the risk in high-risk individuals by almost about 90%. And that's something which would be a crucial thing for us to understand. Though this drug is not currently available, I'm sure people will try to bring in, our own industries will come forward to do it. Molnupiravir, unfortunately, is found to have lower efficacy than what we had thought before. But there is something which is interesting for us to understand. Molnupiravir is now approved by DCGI. If you look at Paxlovid and Molnupiravir, you realize that the Paxlovid, which is a Pfizer drug, it acts against a protease inhibitor, that is Mpro. If you look at Molnupiravir, it tends to act against RDRP, that's a polymerase enzyme. So perhaps like what we have seen in HIV, we may have to use these drugs in combination and try and provide a better effect, but these clinical trials are yet to be done. One thing is very much certain, that this variant may place a huge stress over diagnostic services again compared to what it might do for hospitalizations, for creating infrastructure and trying to isolate these people, because this is a rapidly spreading variant. Perhaps by the time you detect in one, the family would be a cluster which you might detect at this juncture simultaneously. So what could be the immediate future of this pandemic? This is a life full of possibilities. Perhaps what is more likely to happen is there could be a peaceful coexistence that you might see once this Omicron is gone. There would be periodic and focal outbreaks that you might see among those who are vulnerable, and the disease may become endemic. But the major black box that we have to understand is two large countries like India and China, both of them are just showing an increase in the daily new infections that occur. Now, if these infections lead to development of a newer variant, we need to speculate whether it would be good for us or bad for us. We need to wait for the jury to be out. Thank you.
Thank you, sir, for your excellent thought-provoking deliberation. Kindly stay connected. We
Yes.
take the questions in the panel discussion. Now I request Dr. P.C. Manoria, Chief Moderator, to conduct the panel discussion. Request Dr. Murali Mohan and Dr. Radha Sundaram to join. Over to you, Dr. Manoria, sir. I request all the delegates to chat the questions in the chat box so that it can be answered. Over to you, Dr. Manoria, sir.
I'm sure we enjoyed the pleasurable expertise during the discourse of Dr. Raman Gangakhedkar. So, Dr. Radha Sundaram, the first question is, why this nomenclature of Omicron was given to this variant, and what is the strategy that is employed to nomenclate these new variants?
Kindly unmute, kindly unmute. Dr. Radha, kindly unmute.
You are on mute. You are on
Venkatesh.
mute. Dr. Radha, you are on mute. You are still on mute.
I kept trying to unmute, but it wasn't allowing me. Yeah.
Okay.
So thank you very much. Thank you very much for giving me the privilege of joining this. I really enjoyed Dr. Gangakhedkar's sort of discourse on COVID and its evolution. The Omicron variant, as far as I'm aware, it was meant to be named new, but they thought NU, which is the Greek alphabet, but they were worried that it would get confused with NEW, which is new. And so they chose Omicron, which was one of the letters in the alphabet. There are other things on, if you Google it, there are some associations with the number of mutations. But given that it has 50 mutations, I don't think that's actually accurate or true. What is UK strategy? I think COVID has been the greatest leveler in terms of showing how every healthcare system in the world is actually quite fragile. The West have always been arrogant about how they manage infectious diseases, and not having had a pandemic for a very long time, unlike the Far East, unlike Singapore, Malaysia, who actually were hit quite badly with SARS. Despite years of pandemic planning, they were very unprepared for COVID. The strategy in the first wave was similar to elsewhere in the world, and they locked down. But we got overwhelmed and we saw a number of excess deaths. We weren't able to scale up capacity as quickly as maybe other countries were able to do. And we needed to enforce, we needed strict legal policies in place to enforce non-pharmacological interventions like social distancing. Governments tend to be populist and tend to want to police industry, police trade, and actually be very popular with tourism, the airline industry. So despite a lot of scientific advice to the contrary, the government in the UK, and I need to make one thing clear, that the UK is slightly unique in that it has 4 nations. We have England, Northern Ireland, Scotland, and Wales, and actually health is devolved in the other 3 nations. So even if the UK government makes some rules, the Scottish government, because health is devolved, can make separate rules. So Scotland, Wales, and Northern Ireland have been more cautious than England, and actually kept measures like the mask mandates, social distancing in place, despite vaccination. One of the very good things that the UK government did was vaccination, and initially the compliance with vaccinations was excellent. And that is why they have managed to get about 82% vaccinated. However, there is a stubborn group that are not willing to be vaccinated. And although there is much discussion about not allowing unvaccinated people into public places, having healthcare mandates at work to prevent healthcare workers who are not vaccinated from participating in work, all that really is contrary to the sort of general ethos in society here. And I don't think they will come into place. What the UK has done for this wave has that they have encouraged lateral flow testing by members of the public and healthcare workers. So they've encouraged, rather than enforce, they've advised individuals to take responsibility, get vaccinated. They put on booster clinics even during the Christmas period, and they've managed to get their booster vaccinations up to 57%. They've reduced the gap between the second dose and the booster from 6 months to 3 months. They have tried very, very hard. The group that is quite resistant to vaccination in the UK is the Black and ethnic minority group. And they have actually approached mosques and temples to become vaccination centers to try and get those vaccination rates up. They've brought back mask mandates. Scotland and Wales have reduced large gatherings, and instead of legal enforcement, they have left it to personal responsibility, and they have encouraged us to actually test ourselves every day. Now, these lateral flow tests are rapid tests that we do, and everyone in the UK has got access to the tests. You just have to go to your local pharmacy. They're free, so there is no excuse for not using it. And we are encouraged to test ourselves before we meet people. So in Scotland, there is a limit to gatherings in that you can only have 2 other households in your house, even during the festive. On, I think, Christmas Day, they said that we could have more people because people wanted to celebrate Christmas. But otherwise, again, this is not legally enforced because there has been a huge change from having legal enforcement in the first wave. Now it's just advice, and they're relying on people's sense of, social justice to behave. what we've noticed in the hospitals, and I work in Scotland, and I can only talk about Scotland, is that we have reached, I think, about 8,000 cases daily positive. Case positivity rate is about 14%, but the number of patients in intensive care in Scotland has only been about 32. So at this level for Delta, we almost had 150 patients in intensive care in Scotland. So clearly, Omicron is milder and doesn't result in hospitalization to the extent that Delta did. But this is in a nation that is predominantly vaccinated. There are more therapies as well that we're able to give them. Now, as of a fortnight, we are able to give clinically extremely vulnerable individuals, patients who are renal transplant recipients, patients on dialysis, patients undergoing chemotherapy. We are able to give them sotrovimab IV to actually reduce the incidence of hospitalization by 70%. As Dr. Gangakhedkar said, molnupiravir has been quite disappointing because it only reduces it by 30%. It's oral, so compliance would be better, but unfortunately, it only reduces it by 30%. We've also noticed that patients who are testing COVID positive in hospitals, because just like all other healthcare systems, anyone who presents to hospital is now getting screened for COVID. We are finding that 30% of them are actually coming with other issues. So they didn't come in with COVID. They actually came in with a stroke or chest pain, or they were elderly and they had a fall and they came into hospital. We screened them for COVID and they're positive. So they've not come in with COVID pneumonitis. Certainly what we're noticing in the intensive care units with Omicron is the patients seem to be responding to high flow nasal oxygen or CPAP, dexamethasone, an IL-6 inhibitor more rapidly, and the turnover time in critical care has reduced from well over 7 days to about 3 days. We are unable to use a treatment called Ronapreve that we were using, which was a mixture of 2 monoclonal antibodies that was, I think, was marketed by Regeneron in the UK, which we were giving patients if they didn't have any anti-spike antibodies. So every patient who was coming to hospital was being checked for anti-spike antibodies. And if they didn't have it, then we were giving them Ronapreve. What we have found is because of the spike mutations with Omicron, Ronapreve is not working. We're hoping that sotrovimab will work instead, but we still don't have data about that. So I guess, as Dr. Gangakhedkar eloquently put it, there is a change in how governments are going to react to it. We're all watching the space with trepidation, hoping that the virus, although it's become more efficient at transmission, will actually not wreak as much havoc and not cause as many deaths as it did previously. Thank you.
Dr. Murli, usually respiratory infections are more in the winter season, but the Delta variant, we found a paradox. The peak started somewhere April, May, June, not in the winter season. Any specific reason for this?
Not at all, sir. First of all, let me thank Dr. Sambram Biradar and the Gulbarga team for inviting me. Second, thank Dr. Gangakhedkar for an excellent talk, and pay a particular compliment to you. I saw you first, I think, in 1989, and you don't seem to have aged at all, Dr. Manoria. I mean, you look exactly the same as when I first saw you. That's amazing. And of course, you're still doing the fantastic job that you were doing when I first met you. Regarding your question, I don't think there's any specific reason associated with the time of year or weather. I think it's the way the wave has reached us. And I think it's the way future waves are going to reach us. We saw it first hit the United States and Europe, or rather the other way around, China, Europe, and the United States, and then come to India. We are seeing the same kind of progression of the wave with Omicron. We saw it with Delta. And I think it is just the way the pandemic progresses. I don't think it has anything to do. In the beginning, we were expecting, in the beginning of COVID, we thought when the warm season comes around, things will settle down. We learned to our disappointment that it was not a way that we were going to be protected. And the big worry for us now in winter is, are we going to be hit with a combination of, both COVID-19, Omicron and Delta simultaneously, and at the same time get an influenza wave, which we're expecting will happen also. So I've been feverishly vaccinating all my patients for influenza, also those who've already received the COVID vaccinations.
Dr. Radha, the mortality, the pulmonary involvement, oxygen necessity is much less with the Omicron variants. What is the reason? Does it not enter the lungs? What is the specific reason why the oxygen therapy is not required? Why the morbidity and mortality? You are on mute.
Venkatesh,
Please unmute.
Radha,
You are still on mute. You are on mute, madam.
He's trying to unmute, sir. Yeah.
Yes.
Got it now. I don't know what it is, but so the decreased mortality. Can I just ask you to repeat your question? Were you asking
The
me
question
why?
is, the Omicron was associated with decreased morbidity and mortality, decreased necessity of oxygen therapy. So what is the specific reason? Does it not enter the lungs to that extent and damage it compared to the Delta variant? Because there's a paradox between the morbidity, mortality, the lung involvement, the necessity of oxygen therapy, and so many other things.
You're right. There is some evidence from Hong Kong where it is shown that it's more transmissible because of its adherence to the nasal epithelium and perhaps does not attach to the lung. I do wonder if it's actually because of the prevalence of a combination of natural immunity and vaccinations as well that we're seeing this reduced morbidity and mortality. We are treating these patients very differently from how we treated them in the first wave. What we are seeing now is that we are seeing the unvaccinated. So one of the things that was really upsetting and disappointing for most of us in the first and second wave, where we're seeing seemingly well people actually end up in ICU. ICUs in Scotland and certainly in the UK, our mortality, for all comers, so all diagnoses, just not non-infectious diagnosis, is less than 18%. But both in the first wave and the second wave, our mortality increased to over 30%. And that was very, very worrying for us. And we saw people who wouldn't normally have become so unwell, become unwell. But we're not seeing that anymore. We are not seeing the 50-year-old diabetic hypertensive patient on our ventilators in ICU at all. We're seeing three groups. We're seeing unvaccinated healthy people. Very surprisingly, some people as young as 30 with no comorbidities come. We are seeing transplant recipients, patients with hematological malignancies and rituximab, patients who have neurodegenerative conditions, patients with Down syndrome, we're seeing them, and we're seeing pregnant patients. Despite the Royal College of Obstetricians and Gynecologists advising pregnant women to take the vaccine uptake amongst pregnant women in the UK has still been quite low, and they are trying to persuade women to take the vaccine. But as you would expect, pregnant women are slightly reticent about taking any drug or any treatment for danger of impairing fetal health. But I think while maybe the way the virus works has something to do with it, it's still at a speculative stage. I do wonder if it is the combination of natural immunity and vaccine-induced immunity and the presence of so many therapies, which is why we're seeing reduced morbidity and reduced need for hospitalization and reduced need for oxygen.
Dr. Murli, during the Delta epidemic, the diabetics were very badly. A lot of patients also developed mucormycosis. So what is your anticipation? We'll ask Dr. Radha also because we don't have any experience. What is your anticipation? Diabetics and mucormycosis will also be seen this time or it will not be? Dr. Murli, please.
Very difficult to answer, sir, because we don't know what's happening. It certainly seems milder. And as Dr. Radha was saying, the need for high dose steroids, the needs for immunosuppressants being less, I think we will see less of mucormycosis. That's what we're hoping. And a lot of mucormycosis that we saw was in poorly controlled diabetics, or also those who received the various forms of immunosuppression, received excessive doses of steroids for too long. So those are the people we are expecting not to see with the Omicron variant. So I'm hoping, I'm expecting that this will be less of a problem this time.
Dr. Radha, are you seeing diabetics faring very badly, or this time diabetics are not creating any serious problems?
Yeah, we're not. So we did see a spate of diabetics in the first and second wave. In fact, everyone was large, overweight, and diabetic. And we did see a lot of Black and ethnic minority patients. We are not seeing that in this wave. It's too early to say. I mean, Omicron only sort of got on our radar in the middle of November. So it's early to say, but we're not seeing them. We didn't see mucormycosis, but we saw a lot of aspergillosis. And again, as Dr. Mohan says, it's because of the indiscriminate use of steroids and IL-6 inhibitors. So what we saw was that while their oxygenation got better, they then became very susceptible to opportunistic infections. And we were giving antifungals for prolonged periods to these patients with its own complications. We're hoping that we will not, if the length of stay is shorter, they don't need excessive therapies, and the complications should also be less. So hoping that we're not going to see the need for antifungals.
What about thrombogenicity of the Omicron? Unlike the Delta, which we have severe thrombogenicity, thrombosis in the arteries, veins, microcirculation, everywhere.
So again, too early to say. We have now, just like India as well, we give all of them increased doses of antithrombotics. We use enoxaparin, and we do anti-10A monitoring, and we target our anti-10A to these patients. And we're not seeing it just yet. Still too early to say, but hopefully if the disease burden is not so severe, we should perhaps not see as many complications, or at least we'd hope.
Gloria, can I ask Dr. Radha a question?
Yes.
With your permission? Yeah.
Yes,
so I was struck by the fact that you said that you've been seeing patients who come in with a stroke or a cardiac event and then find they have COVID. Do you think it's coincidental, or do you think it's a cause-effect kind of thing?
It's coincidental. So these patients aren't presenting like the COVID strokes that we saw previously. We're not seeing them with COVID myocarditis, and they actually don't even have a temperature, which is really, really interesting. So one of the things that we're struggling is with track and trace and control of the disease at the sort of societal level. Previously, it was if you had a temperature, you may have it, so go and get tested. Whereas now you almost have to test yourself every day because the symptoms are so innocuous and non-specific, earache, a runny nose. So the patients that have come in, my hospital over the weekend, we had patients who came in fractured necks of femur, elderly patients who had fallen and they were COVID positive, but they had no symptoms, and their X-ray didn't look like a COVID X-ray at all. And they didn't have an oxygen requirement.
Dr. Murli, what strategy we should adopt for the booster dose in India? The same vaccine should be re-injected, or any other vaccine can be injected, or there are some vaccines which are more potent, will provide greater immunity and greater prevention from the Omicron virus? Your viewpoint.
Yeah, I don't think we have an answer. I think that's a very, very good question, a key question for us. My own personal impression, and this is completely a personal impression, is that a mix and match strategy has been shown to work with other vaccines. And I think, that's what is going to work here too. It makes sense. It makes sense because I think, changing the antigen would actually make sense. Changing the way that the spike protein is engineered makes sense. I have been worried from the beginning that the virus used for delivery of the DNA or RNA is going to be, we are going to develop antibodies to the adenovirus, for example, that's available in the AstraZeneca vaccine or our own Covishield vaccine, and make it less effective. So the Sputnik strategy of using two different viruses for delivery actually made a lot more sense. But to me, it makes the greatest sense to change the vaccine we're going to give it. But that's again a completely personal opinion.
Dr. Radha, we have
Manoria, can I ask you a question?
Sure.
Dr. Murli or Radha, Venikan, the Omicron less mortality, less hospitalization, it is because of more upper respiratory involvement than lower respiratory involvement?
It would appear so. I think, again, at this stage, it's still very speculative, but that's what researchers in Hong Kong are saying, is because it's got, more adherence to the nasal epithelium and perhaps doesn't travel. But a lot of what we saw with COVID was an exaggerated immune response as well. So I'm not sure why it's not evoking that sort of an exaggerated immune response with these patients.
When we see the Guy's hospital data, ILD very less, lower respiratory involvement very less compared to original one compared to Delta and Omicron.
Yeah.
Means anything to do why lower respiratory involvement is less in Omicron? I
Dr.
couldn't get
Murali
answer.
was-
Once it is upper respiratory involvement, a variant affecting only one respiratory tract more than other part of the respiratory system, because local mucous membrane is different, upper respiratory, lower respiratory. Is there
That is the
maybe
peculiar
reason?
feature. That is the peculiar feature. The reason I don't think is very clear.
One of the clues may be from what Dr. Manoria said earlier. You know, a lot of the pathology of COVID-19 appears to do with the vascular system, and maybe with the mutations in the spike protein, the plentiful mutations in the spike protein, we're not seeing that much affinity towards the vascular system, which, you know, it's also struck me from what one of the slides Dr. Gangakedkar showed, was that you have much less loss of smell and taste than you did with the earlier variants. You know, to me, that's a sign that maybe it's not really affecting the upper respiratory tract as much, or is affecting it differently from the earlier variants. You know, so there is something peculiar going on with this virus.
So the main difference is in ILD. The alveolar shadows in Delta more than Omicron.
Absolutely.
Can Dr. Raman can throw some light on this, sir? Dr. Gangakedkar, sir?
Yeah. No, I think we cannot speak more than what has been reported so far. To my mind, the only evidence is that it doesn't go through the lungs, and that's something which may be making a difference. To my mind, it's very difficult to understand. But the second thing, which is also important, as I say, you know, for preventing infection, you need high titers of neutralizing antibody. Because if my incubation period is going to get short and shorter with new variants, I'm not likely to provide sufficient time for my T cells to generate neutralizing antibodies immediately. But these neutralizing antibodies which the T cells generate perhaps act when it comes to modifying disease behavior. No, but as I keep on saying, these are completely speculative statements. We don't know anything, but it is possible. That's all that I can think about.
Dr. Radha, there are 4 pillars of COVID treatment: antiviral therapy, anti-inflammatory, anticoagulation, antibody cocktails. So what message will you give rise to our physicians in the context of the new antivirus, molnupiravir and nirmatrelvir? What is their utility? They should be used. How often? Dose? How many days?
Yeah, I think one of the things that, and I learned it in India, and I think doing common things uncommonly well work. That is, if there is a vaccine offered, please go and get the vaccine. If you are unwell, present to hospital, give them oxygen, that's medical grade oxygen, start them on steroids. We are not using antivirals in hospitalized patients. If patients present to hospital, we are not using either sotrovimab or molnupiravir. We're using sotrovimab, and actually the indications of molnupiravir are actually very, very narrow. We are only using them for nursing home residents and care home residents. Sotrovimab is being used for the clinically extremely vulnerable patients who are testing positive, and they're trying to give it to them as soon as they actually test positive to prevent hospitalizations. But we're not giving it to them once they come to hospital. Once they come to hospital, they get dexamethasone. They get, if they are having an oxygen requirement, they're getting increased dose of an antithrombotic agent. And then they're getting antibiotics if they appear to have a bacterial infection. Strict hand hygiene, cohorting so that they're not in contact with other patients, and actually not trying to complicate matters by giving them too much medication. And we're actually seeing that the length of stay is less. Initially, when REMAP-CAP, which was the largest randomized controlled trial looking at COVID therapies after recovery, the recovery trial showed that IL-6 inhibitors like tocilizumab and sarilumab were effective. We were using it on all hospitalized patients who had a need for oxygen. But again, we found to our dismay that it made these patients very immunosuppressed and succumbed to opportunistic infections. So their oxygenation improved, but then they had life-threatening opportunistic infections. We saw an increased rate of Klebsiella infections, Pseudomonas infections, Aspergillus infections. So now we are much more reticent about throwing everything at them. And I think giving them oxygen if they need it, giving them steroids, and increased antithrombotics is perhaps where the UK ICUs are pitching their treatment.
We have used steroids and tocilizumab. Any role of JAK inhibitors like baricitinib or tofacitinib? Any data emerging?
There is some promising data for the JAK2 inhibitors, but we are only able to use them within the trial. So if we recruit a patient and they're randomized to receive baricitinib, then we give it to them. But we're not allowed to do any off-label prescriptions of JAK2 inhibitors yet.
Dr. Murli, any comments on the antibody cocktails which we have used in India also? Or you have any personal experience of Casirivimab and Indevimab?
So we've used quite a lot of, the Regeneron, Casirivimab, Indevimab, tongue twisters, I'm sorry. But yeah, we've used quite a bit of that. The disappointing thing is that they say it's not very effective against Omicron. My expectation is that once we get Sotrovimab, we'll be using a lot of it because that seems to be what the CDC is also saying. And my anticipation is that we'll be, after the Pine Tree trial results, we'll be using it in combination with Remdesivir, provided patients come in very early. And that really is the challenge. How soon do patients come in? Do we catch them within the first week and start this treatment? We have been reserving the antibody cocktail only for the very vulnerable people. We make it very clear. It's expensive in India. 60,000 to 1,20,000 is not easy for most people to afford. So we are reserving it only for those who are really vulnerable, and others seem to get better. The ones who are not at high risk, we are not using it for. And that seems even more the strategy that we should be adopting with Omicron, given its current apparently, fairly mild outcome.
Dr. Murli, what is your anticipation for the third wave in India?
I think it's coming, sir. I think what we are seeing everywhere, we're getting reports everywhere, is that we are going to see the third wave. Hopefully, like previous waves have shown us, or previous pandemics have shown us, the third wave is going to be milder. Though it may rise very sharply, I'm anticipating that it will also pass away quickly, given the high rate of herd immunity that already seems to exist and the availability of new drugs. And I think one important thing is that we've learned better over the course of the pandemic what to do, and more importantly, what not to do.
So with this, I hand over the mic to Dr. Sangram to address the question answers in the chat box.
Yeah, thank you, sir, for the wonderful discussion and the moderation. Since there are no much questions in the chat box, because everything is crystal clear, speaker has made it very clear, panelists have made it clear. So what we'll do is we'll have one take-home message from each and conclude the session. So I request Dr. Gangakhetkar, sir, your take-home message of the topic today for the audience.
Just one simple one. If we were to have optimistic convenience bias based on speculations, it seems we are very close to this disease becoming endemic, but we shouldn't speculate more unless we have real evidences. Perhaps we need to continue to be very vigilant in our approaches, including the population as well, not only us. And we need to be very careful when it comes to public speech, especially trying to pull down Omicron and say that nothing is going to happen. As it is, people are people. They may take the message just the opposite.
The fact that cases rising in Mumbai and Delhi, sir, you are concerned over that.
Yeah, of course they will rise. But as I said, no, when you are in a risk mitigation phase, as it is, the infection has established its roots everywhere in the country. So you should actually be looking at its impact on health sector. So you should count number of hospitalizations, number of deaths that occur, number of people on ventilators, those kinds of parameters. Though numbers are also important because they will tell you a different story whether there is some kind of a cluster which may lead to development of a new variant. But beyond that, numbers would have less value if what we have seen is to be believed.
Yeah, only we have to wait and see. Time is the healer now. Anyhow, thank you, sir. I request Dr. Murali Mohan, your take-home message on the talks.
I think, one of the lessons that we've learned from all the waves of COVID-19 is that this is a highly mutable virus. It is going to change. It's going to keep changing. It's not going to go away. We're going to have to learn to live with it. And the time-tested strategies of physical distancing, masking, hand hygiene, and vaccination are the only that, constants that we are going to have to observe. They're going to have to become a way of life for all of us. Drugs will come and go. The virus will mutate to overcome these drugs. The virus will mutate to overcome vaccines. We're going to have to constantly keep evolving just to keep in pace with the virus, the so-called Red Queen hypothesis. We are seeing played out in fast forward this time. So please keep the standard for time-tested strategy, and everybody needs to adopt them.
Yeah, thank you, sir. Dr. Radha, your final message to the audience.
I feel actually very inadequate to actually give you a take home in terms of scale of cases. The assembled audience have seen far more than I have. In the UK is an island nation, and despite the fact that we have a pretty well-established state-provided healthcare system, we have been humbled by this disease. And I think I've learned more this afternoon than I can ever share with all of you. So I'm just thanking you for the opportunity to participate in this. Thank you.
Yeah, thank you. Thanks a lot. Dr. Antani, sir, your take-home message. Any comments you want to make? Dr. Antani? Kindly unmute, sir. Unmute.
You are muted. He's still muted. Yeah.
I personally feel we should have more testing and more isolation. Very simple isolation, but very rapid testing, including for Omicron.
Okay, sir. Thank you. Dr. Narsimlu, sir, your
Well, definitely one message from my field of rheumatology. People who are on DMRDs and steroids, we should not stop them. The COVID and rheumatoid HLE, you stop the drugs, the mortality more. So those drugs should not stop. And second thing is, things not covered. Vaccination pregnant women is safe, and postpartum also is safe. So people with the pregnancy and breastfeeding, they can take the vaccine.
Thank you. Sir, lastly, Dr. Manoria, sir, your final message to the
Each citizen of the country must be very clear that if you want to remain COVID-free, adopt simple preventive measures.
Yeah, thank you, sir. Finally, my comment will be getting adjusted to the existing like social distancing, masking, though it's very difficult in our country, but we have to follow it very strictly. That is the only answer, but how long we will be sustaining, we will not be knowing. So anyhow, thank you once again for all the participants, the attendees who have joined from all over the country. I thank all the faculties for making a wonderful session, interactive. I thank Dr. Y.P. Munjal sir for inaugurating the session, Dr. P.S. Shankar, Dr. Antani, Dr. Muruganathan, and all the faculty for participating. I thank one and all. Lastly, kindly be safe, stay safe, take care. Wish you happy new year in advance. Thank you one and all. Thank Manoria sir for wonderful moderation. Thank you, Dr. Murali, Dr. Radha, and all the attendees. Thank you one and all. Good night. Stay safe.
Right.
Thank you so much, everyone. And a happy new year.
Yeah.
Happy New Year to all of you.
Happy New Year.
Happy New Year, all of you.
Yeah.
Manoria ji, आपको भी.
Thank you, sir.
गंगा गंगा करते